Hope Cook here with Dermcast.live. Today I have Dr. Travis Vandergriff. Dr. Vandergriff is the Director of Dermatopathology at University of Texas Southwestern Medical Center. He's also an Associate Professor of Dermatology and Dermatopathology. Welcome, Dr. Vandergriff.
Thank you.
So I loved your lectures on dermatopathology, and that's not something that normally keeps me riveted to my seat, but you did a really great job with that.
Thank you. Yeah, dermatopathology is a topic that can be a little bit intimidating and also can be a little bit dry if not presented in a clinical context. But I think it's such an important part of practicing dermatology, and it's something that I'm really interested in and forms a big part of my practice.
Yeah, and as a new graduate, so many dermatology PAs are, I'm guessing like I was, intimidated by dermatopathology and how to word it on their path report and how to talk to the dermatopathologist.
Yes.
Do you have any advice for new graduates?
Yeah, so I think the first thing I would say is really try to get to know your dermatopathologist and form a relationship. A common mistake is to think of pathology in the same way that you would think of a laboratory test that's like a blood test or a sample that's run through a machine. And that's the mistake that I see a lot of people make when they're first getting into practice. And the assumption is basically like that a pathology interpretation is completely mechanical and infallible, and really it's just another person on behind a microscope who's looking at information and making an interpretation. So it's kind of analogous to the way that you would see a patient and integrate what you're seeing and then come up with a diagnosis. Somebody else may look at that same patient and collect the same data but arrive at a different interpretation. So pathology is similar in that there's not always one single interpretation, and so having communication is really an important part of making sure that your dermatopathologist is aware of all the important clinical information, but also that you understand what they're seeing and what they're reporting back to you. So your dermatopathologist is really one of your strongest allies in your clinical practice, and the more connection you have with them and communication you have with them, the better the relationship will be, and also the better you're able to use their information to help you diagnose and treat your patients.
Yes, I mean more than once, probably every week, my dermatopathologist and I are on the phone and I'm asking, could it be this? Did you look at the picture? And
absolutely,
so
yeah. And I think most of my colleagues in DermPath are very interested in receiving as much clinical information as possible, and also to hear follow-up on patients, or if you have additional questions or new information, or if the diagnosis that was reported doesn't really fit or is not congruent with what you're seeing clinically, to kind of go back to the drawing board and start again. And that's not at all a something that would be perceived as challenging or an insult in any way. It's a way to kind of refocus and start a new interpretation of that biopsy. So anytime you get a report back that doesn't quite add up, it's definitely worth calling and explaining what you're seeing and why you think it may be something else.
Yes. Can you talk a little bit about why it's important to tell your dermatopathologist if a lesion has been previously biopsied, specifically like a melanocytic lesion?
Absolutely. So that's part of the clinical history that's very helpful with melanocytic neoplasms. So when a nevus is biopsied, if it comes back or recurs, the scar tissue can alter the appearance in that recurrence, and it can make it look really disorganized and kind of irregular. And so it can basically mimic a melanoma at that point. So it can make the appearance unusual and could be interpreted as a melanoma. And in fact, those recurrent nevi were originally described as pseudomelanoma because it so closely resembles melanoma. And so getting that information is important. A lot of times we can see the scar tissue and may infer that a biopsy had been done, but it's very helpful to go ahead and get the information. And then also to know exactly what was biopsied. Was it the whole lesion and now it's come back, or was this a small part of a larger lesion? So if a biopsy has been done, it's helpful to know that that was done, and then what did it show?
Yes, I have learned to ask my medical
Yes.
assistant to put smaller piece of larger lesion
Yes,
if I have to do it.
absolutely, yes. If you're doing a biopsy that's a partial biopsy, that's very important for your pathologist to know, because they need to factor that into the interpretation.
What about rashes? I know it used to be the case that we were told to always do punches on rashes. Do you still think that's the
So
case?
I think taking a dogmatic, like always approach, I kind of discourage that. I think generally speaking, punch biopsies have a lot of advantage for rashes. And what it allows you to do is to see the full thickness of the skin. So not just the top layer or epidermis, but the dermis, and sometimes even the layer beneath that, the subcutis. And what that can help you with is knowing how much inflammation is present and where in the skin it is influences your diagnosis. So if you do a shave biopsy, you can inspect the epidermis, but the dermis, only the top part would be represented. And so there's a chance that there's something going on in the deeper dermis that you just wouldn't recognize. So I think shave biopsies can be done for rashes. There is that limitation that you wouldn't necessarily see the deep part, and you might get a diagnosis back that's maybe not quite as specific as what you could have gotten with a punch. However, there are some scenarios where a shave biopsy may be equally as valid or even preferred. So maybe you're doing a shave for like a cosmetic reason, or for the patient doesn't want to have any sutures put in. Sometimes mycosis fungoides is a good diagnosis to consider doing a shave biopsy on. So I don't think that shave biopsies are a complete no-go for inflammatory skin diseases, but just thinking about how, knowing that the depth of the inflammation would be something that you can't really check on a shave.
Gotcha.
So I generally speaking, I prefer punches, but shaves are not a bad way to start also.
Yeah, and if you're doing a melanocytic lesion,
Yeah.
you need to do the shave to get...
Yeah, so again, there's the kind of unifying concept for biopsying melanocytic lesions is if you can get the whole thing, you want to do that. And the reason being, when we look at melanocytic lesions microscopically to make the diagnosis, the very first thing we look at is the bird's eye view, what we call scanning magnification, so very low power bird's eye view, and you assess things that have to do with the size and the circumscription and the symmetry of the lesion. And so all of those things require seeing the entire lesion. Now obviously sometimes we can't biopsy the whole thing. There's limitations, anatomic or cosmetic limitations, and so it's okay to do partial samples, but knowing that a partial sample is potentially less specific and can give you what's called sampling error, meaning let's say there's a pigmented patch on the cheek, and part of it is a lentigo and then part of it is a melanoma in situ. You could inadvertently biopsy just the part that's a lentigo, so that's the limitation of partial biopsies, is just knowing that maybe there was a sampling error.
Yes, and I also wanted to highlight something you said about syphilis.
Yes.
And will you tell our audience?
Sure, yeah. So we presented a case yesterday in the session on skin infections of syphilis that was clinically pretty standard presentation, but there was a curveball in the history, having been a negative RPR test, which can happen in syphilis for a number of different reasons, but it sort of deflected the attention away from syphilis when it otherwise was pretty good clinical presentation for it. But we talked about ways to make that diagnosis, and one of the ways is to do a biopsy, and the tissue can be checked for the bacteria or the spirochetes that cause syphilis. A punch biopsy is probably the best way to go for syphilis because, again, sometimes those bacteria are in the blood vessels in the deep part of the skin, and it's the preferred way. If you aren't thinking about syphilis and you did a shave biopsy, you might still be able to detect it. But if it's on your mind and on your differential, then I would recommend doing a punch biopsy for the lesions that you're concerned could be syphilis.
And are there certain stains that we need to specify?
There are stains that can be done. They are immunohistochemical stains. Now, there's some old school stains that have kind of fallen out of favor just because they're not as specific and they're just a little technically a little bit messier appearing, but there is a really nice stain for it. I don't think that you would have to indicate that on your report, though. If you simply put in the differential syphilis as an option, it would be pretty standard for the pathologist to recognize that and order the stain if it was suspicious.
And before the cameras were rolling, we were talking about how syphilis has really ratcheted up lately.
Yes, definitely. So syphilis is a diagnosis that has a lot of history in our specialty. And for a while, I think there was some kind of decline in the numbers, but definitely over the last decade or so, we're seeing increasing numbers of syphilis, and it's making somewhat of a resurgence. So it's a diagnosis that has many different clinical presentations and is often recognized in textbooks called the great mimicker, which means that it can look like so many other diagnoses. And for that reason, it's always a good diagnosis to keep on your differential for a number of presentations. And so syphilis can really fool you clinically because it looks like so many different other diagnoses.
And it's one you don't want to miss.
It's one you don't want to miss because there can be some long-term complications, neurological, cardiovascular. Of course, in pregnancy, it can have devastating effects as well. So it's a diagnosis that we would definitely want to make as early as possible. The treatments are essentially curative, so penicillin is still the mainstay of treatment, and once a patient is appropriately treated, it's a disease that in most patients can be totally cured. So making that diagnosis is really important.
Yeah, so punch biopsy if you can.
Punch biopsy if you can. If you're concerned about syphilis, I would also recommend go ahead and checking the blood tests, either the RPR or the syphilis-specific antibodies, and concurrent to your biopsy, and so you can have that information along with the biopsy results as well to really cover those bases.
Okay, good information. Any other tips for people who are starting out in dermatology, or just tips in general that you wish we all knew?
Yeah, so I would say take every opportunity that you have to learn from your patients and be observant. So you know, when we study from textbooks, we see the classic presentations presented, oftentimes just sort of like what has been described as the prototype of a specific disease. But the patients that come see you, most of the time there's something that's a little bit of a variant. It's not quite going to follow the textbook. So you have to build in your mind a database of images and visual appearances that over time you kind of compile. It's sort of like compiling a file in your mind of images or appearances, and then you're able to recognize those subtle variations in a common disease like psoriasis, for example, where there's a classic textbook presentation, but then there's those everyday, slightly unusual or variant presentations that also are psoriasis, but don't look quite like the textbook. So just be observant of your patients. Take as many pictures and put them in the record, the medical record, as many pictures as you can. It helps your derm path, and then also it helps you monitor treatment outcomes. So I think that documenting with photographs is a big bonus of the electronic medical records.
Thank goodness we have those now.
Yes.
Yes, this is all such good information. Thank you for joining us today.
Sure.
This is Hope Cook coming to you live from Austin, Texas.